So let's start with the antiarrhythmics. These are particularly challenging, especially for me to remember. They have tricky names and they are in many classes, and you absolutely must remember back to your physiology to understand how these drugs work. These drugs are split into different categories based on their mechanism of action. As you can see here on the slide, Class 1 antiarrhythmics block sodium channels. All of these drugs slow or block conduction some way or another, and they do so more effectively in cells that are frequently depolarized. All Class 1 drugs slow down phase 0 depolarization. Remember, we have 4 phases: 0, 1, 2, 3, and then 4 is our baseline. So all of phase 1 are inhibiting some element of the phase 0 upstroke. They're split into subclasses A, B, and C based on the specific details of the pharmacokinetics. Class 2, 3, and 4 are just antagonists of a receptor or channel that we already know a lot about. So Class 2 are just beta blockers, 3 are the potassium channel blockers, and 4 are calcium channel blockers with a high specificity for the myocardium. I'm going to set you up for all of these drugs just like how we went through digoxin. We must understand the mechanism first, and then from there we can certainly derive the expected clinical outcome and adverse side effects of the drug, with some random exceptions that you just have to squeeze in your brain because they don't always have a logical physiologic explanation. One thing you unfortunately have to memorize are the names of the drugs and which class they belong to. I wish there was a way to make memorization not something, but it's a big deal for step 1. That's just how it is. So let's go ahead and talk about the Class 1 antiarrhythmics. The 3 subgroups are A, B, and C. They all inhibit sodium channels in a state-dependent manner. Now what does that mean, and why do I say it? State-dependent manner. We discussed how the fast sodium channel that is responsible for the upstroke of the phase 0 depolarization has a voltage-sensitive activation gate. So this is the voltage-sensitive activation gate. When there's a change in the transmembrane potential to a sufficient enough positive threshold, this gate will swing open, and the gate will open and allow the influx of sodium. The activation gate opens, but the pore is quickly blocked by the inactivation gate. So the inactivation gate is actually open at the state when the sodium channel is ready to depolarize. It depolarizes and we get an influx of sodium, but then the inactivation gate slams shut despite that the activation gate is open. Sodium tries to move in, but it can't because the inactivation gate slams shut. So the inactivation gate quickly blocks the pore that the activation gate opened. Drugs have this period to bind the inside of the fast sodium channel to slow the restoration of the activation gate and the return of the inactivation gate to the waiting for depolarization position. So these drugs prefer to have more opportunities to bind the inside of these channels. When is that activation gate going to be open on the extracellular side of the membrane? Well, probably in this state right here, when this activation gate is still open and this inactivation gate is slammed shut. Or in this state, when the inactivation gate is still in its normal position and the activation gate is open. So the more frequently we depolarize, the more opportunities these Class 1 antiarrhythmics will have to bind these channels. So more depolarizations, more times that the channel cycles through this process, and more times that it will be able to bind because the channels will be more frequently in this state and in this state. And that is why they are state-dependent antiarrhythmics. Let's talk a little bit more about Class 1A. So these bad boys are quinidine, procanamide, and disopyramide. So these guys block the fast sodium channels that are responsible for the phase 0 depolarization. Big deal, we already knew that. That's what all Class 1s do. But look at your diagram and see how the slope of the phase 0 is not as steep. Normally we would expect this to be a completely straight line almost. So this line is telling us that we're doing something to decrease the velocity at which we're allowing sodium to flow into the cell aka we are somehow manipulating the sodium current. Do you remember what we said that the slope of the phase 0 is dependent on? It is a direct representation of how many, so a number of sodium channels you have in the ready to fire state, because the influx of sodium across these channels will be much greater if you have more channels available and participating. So if you have an increased number of sodium channels, you have an increased sodium current. And that means that you will have a much faster and steep upstroke. And if you give someone quinidine, procainamide, or disopyramide, you block the number of available sodium channels in the ready-to-fire state, and therefore we decrease the slope of that upstroke. And that is why there's a shift. Another important thing that you absolutely just have to know about these Class 1As is that they also bind and block potassium channels. It's not in your first aid book, but that's what they do. Guess what happens when you block potassium channels? You prolong the phase 3 repolarization because you're not allowed to pump out as much potassium out of the cell to restore the normal transmembrane potential. So you prolong the time that it takes because there are less potassium channels available for that repolarization, phase 3. So do you see here the extension of the repolarization phase because we have blocked the potassium channels? We have extended our depolarization by not only slowing down the initial phase 0, but we've also slowed down the phase 3. So now the depolarization that normally lasts this period of time has now been extended to last a much longer period of time. So let's repeat to make sure we have seen this in our minds and remember it. How do these Class 1A drugs work? They block fast sodium channels responsible for our phase 0 depolarization and potassium channels that mediate our repolarization of phase 3. How is this advantageous for us? Why would we ever give this to anybody? Well, they preferentially bind channels that are being opened a lot because they sit in the transmembrane channel. The Class 1A antiarrhythmics need to be inside the channel, which can only be accessed if you have the activation gate open and the inactivation gate in its normal position or closed. And that only happens after you depolarize. That is why they are particularly beneficial in patients with reentrant or ectopic supraventricular and ventricular tachycardias. So reentrant or ectopic supraventricular tachycardias. Now why is that? Because these channels are being stimulated to open a lot by abnormal circuitry. They're depolarizing much faster than our heart would desire, pun intended, so you need to give them something to slow them down. And what better thing to do than give them a drug that can directly go for the cells that are being depolarized way too much. Alright, so super high yield are the side effects. Let's talk about quinidine first. For this, you need to watch out for its ability to disrupt the conductance of the vestibulocochlear apparatus. Now, what is the vestibulocochlear apparatus for? Well, it's associated with the ear, and it provides this ability to detect where we are in space and maintain balance. Not only can quinidine affect the potassium and sodium channels in the vestibulocochlear apparatus, but it can also mess with central nervous system neurons. So you can get headache, tinnitus, which is a very loud ringing sensation that is constantly flowing like this, confusion, hearing loss. Just think, if you disrupt the ability of the neurons coming from the vestibulocochlear apparatus to conduct to the brain, it will be perceived as hearing loss by the brain. And last, but very importantly, visual problems. They call a constellation of symptoms of headache, tinnitus, confusion, hearing loss, and visual problems synchronism. And that is your high yield side effect for this class of drugs. Now what about procainamide? We talked about procainamide a couple of slides ago when we talked about hydralazine. So we already know it's famous for causing a drug-induced lupus. Do you think that you might get a lupus-like presentation in a patient and then you get asked what drug this patient might have taken for a supraventricular tachycardia? You bet. If I was writing a question, that is exactly how I would go about asking you if you know the side effects of procainamide. Now, disopyramide is a very unique one. It's the big bad guy here. It has an incredibly potent effect on suppressing the fast sodium channels to the point that it can actually lead to such low conductance that you suppress the contractility and you induce systolic dysfunction and you get acute heart failure in someone. So again, disopyramide, big bad guy, incredibly potent effect on suppressing the sodium channels. If you don't have any sodium current conducting through these cells, you get no contraction and you get immediate systolic dysfunction and acute heart failure. All of these drugs affect this phase 3 repolarization. So all of them can lead to torsade, especially disopyramide because it has a very potent effect. Anytime we start messing around with the potassium channels responsible for our repolarization, we can predispose for prolonging the QT interval. And we take the risk of having depolarizations either too early or too late relative to normal. Electrophysiologically, this will be preceded by a prolongation of our QT interval because the QT interval includes the repolarization phase of our ventricles. So, prolong the QT, increases your risk for torsades. Torsades can progress into ventricular fibrillation, and that is a terrible situation because you want your ventricles to contract in a unified, powerful force to get all the blood out of the ventricles. And if you are fibrillating or quivering those ventricles, there is no unified contraction. And that is how people die, these Class 1A antiarrhythmics. Now what about the Class 1B? Only 2 drugs here, lidocaine and mexiletine. These guys inhibit the same fast sodium channels that we discussed in the 1A group, but they actually shorten the action potential. Now how does that make any sense? And they shorten the effective refractory period. How is this possible? If we're blocking the channel, shouldn't we prolong our action potential? So flashback here, we just talked about these sodium channels in the physiology section and a slide ago. We have activation gate that is closed, inactivation gate that is open. We depolarize, we open our activation gate, and then our activation gate remains open until eventually we close our inactivation gate. So the activation gate that opens to start the influx of sodium ions across the transmembrane channel is an important consideration, and so is the inactivation gate that shuts after a few milliseconds to stop the influx of sodium. These 1B antiarrhythmics act just like the inactivation gate. So basically, they replace the function of this inactivation gate. So at this phase, before we even reach this, these antiarrhythmics say, well, I'm going to be an activation gate, immediately block this channel. So they stop the sodium conductance by acting like a pharmaceutical inactivation gate. And that shortens the actual action potential because we stop sodium current before we would normally expect, because the inactivation gate is normally responsible for the closure of the channel and preventing any more sodium conductance. So quick summary, lidocaine and mexiletine act like an inactivation gate that comes in way before you would expect the normal inactivation gate that is part of the channel to shut. This shortens the action potential because we stop the influx of sodium sooner than normal. We are still blocking sodium current or affecting it in some way, so the initial velocity of phase 0 is represented by a decrease in the angle at which it transitions from phase 4 to 0, and it shows up a unique diagram in the fact that we have also not only decreased the slope but shortened the action potential. These drugs work best in states after a myocardial infarction, where the cells are undergoing anaerobic respiration and have accumulated a bunch of protons and lactic acid. They are excellent for ventricular arrhythmias because the short action potential of the atriomyocytes doesn't give these drugs much time to bind and block the sodium influx. So this is mainly used for ventricular arrhythmias because atriomyocytes sodium channels close very quickly. That inactivation gate slams shut much faster than the ventricular myocytes. The side effects are due to the ability of these drugs to enter into the central nervous system. They can also excessively depress myocytes. They are very lipophilic, so they can easily enter the brain. Anytime you block a sodium channel in the brain, you need to watch out for symptoms of blocking your brain's ability to conduct signals along its neurons. And this can lead to confusion, paresthesias or tingling of the extremities, maybe potentially the face, the lips, and even a seizure-like activity. So the big one to watch out here are seizures in someone that is receiving some sort of Class 1B antiarrhythmic. Now let's go on to the Class 1C. We're rolling right now. Let's keep this going. Class 1C antiarrhythmics are the ones that you rarely see clinically because you should remember these as Class 1C kill. Do you still need to know them because patients took them in the past? Yes. Check out the slope on that diagram. Look at this. That is extremely intense. It looks like something you could even walk up compared to the slope of the 1A and 1B antiarrhythmics. What is that telling us about the ability of the 1C agents, which are flecainide and propafenone, to inhibit these sodium channels that are responsible for our phase 0 upstroke? They're super potent and strong. I mean, these are like the Arnold Schwarzeneggers of the Class 1 antiarrhythmics. You should never ever give this to a patient who just had a myocardial infarction because you can suppress conductance, particularly in the AV node, and the cells in the ventricles that just suffered severe membrane alterations due to ischemia and therefore have abnormal ion concentrations intracellularly and extracellularly because the sodium-potassium pump is deprived of ATP. Those cells are just waiting for an opportunity to start beating on their own if you block the override signal that comes from the AV node.